Hello, my name is Tina Cascone. I'm a thoracic medical oncologist at the University of Texas MD Anderson Cancer Center in Houston, Texas. At this ESMO 2023 Congress, I presented the results of the CheckMate-77T. This is a phase 3 study comparing a neoadjuvant nivolumab plus chemotherapy with neoadjuvant placebo plus chemotherapy followed by surgery and adjuvant nivolumab or a placebo for a previously untreated resectable stage 2, 3B non-small cell lung cancer. The rationale for this study stems from the evidence that nivo plus chemo is the standard of care neoadjuvant treatment for eligible patients with resectable non-small cell lung cancer based on improvements in EFS and PCR as compared to chemo in the CheckMate-816 study. And so a perioperative treatment approach, including adjuvant nivo, could potentially further reduce the risk of disease relapse and improve the clinical benefit in patients with resectable non-small cell lung cancer. The CheckMate-77T study is a global randomized double-blind phase 3 study that is evaluating neoadjuvant nivo plus chemo followed by surgery and adjuvant nivo versus neoadjuvant chemo placebo followed by surgery and adjuvant placebo in patients with resectable stage 2, 3B disease. And the results I presented at this ESMO Congress are from the pre-specified EFS interim analysis as well as results of secondary endpoints and key exploratory analysis. This study included patients with resectable stage 2A, 3B disease presentation with, according to an AJCC 8 edition. The patients also had to have no prior systemic anti-cancer treatment, an ECOG performance status of 0 to 1, and no EGFR mutations or non-ALK alterations. Stratification factors were tumor histology, disease stage, and tumor PD-L1 expression. And a total of 461 patients were randomized 1-to-1 to receive neoadjuvant nivo plus chemo every 3 weeks for 4 cycles, followed by adjuvant nivo for 1 year, given every 4 weeks, or neoadjuvant placebo plus chemo, followed by adjuvant placebo. And after the last neoadjuvant treatment, as well as radiologic restaging, surgery had to be performed within 6 weeks. The primary endpoint of the study was EFS by blinded independent central review, and the secondary endpoints were PCR and MPR, OS, and safety. An exploratory analysis included EFS by PCR and MPR status and EFS by adjuvant treatment status. The data presented at ESMO 2023 were based on the September 6, 2023 database lock with a median follow-up of 25.4 months. And the pre-specified interim analysis of EFS was scheduled to take place when 185 events had occurred. As of this database lock, 189 events have occurred, and as of this database lock, overall survival has not yet been formally tested and continues to mature. As far as the baseline patient characteristics in the study, those were generally balanced between treatment arms. More than 50% of patients were from Europe, and more than 20% were from Asia. Approximately 2/3 of patients had stage 3 disease, and about 90% of patients in both arms currently smoke or had smoked in the past. More than 50% of patients had tumor PD-L1 expression of 1% or more, while about 40% had tumor PD-L1 expression less than 1%. And most patients received carboplatin-based chemotherapy in both arms. Almost all patients in each arm received neoadjuvant treatment, with at least 85% completing 4 treatment cycles, and the study drug toxicity was the most common reason for a neoadjuvant treatment discontinuation in both arms. 78% of patients in the nivo arm and 77% of patients in the chemo arm received definitive surgery. The most common reason for cancellation of surgery was disease progression in both arms, but with more cancellations seen in the chemo arm. And only 3% of patients in the nivo arm and 2% of patients in the chemo arm canceled surgery due to adverse events. Nearly 2/3 of patients across both arms received adjuvant treatment, with a median number of 13 doses administered in both arms. Toxicity was the most common reason for not receiving adjuvant nivo, while disease progression was the most common reason for not receiving adjuvant placebo. Of the patients who received adjuvant treatment, 60% of those in the nivo arm and in the chemo arm completed 1 year of therapy. And the most common reason for discontinuing adjuvant therapy were a study drug toxicity in the nivo arm and disease progression in the chemo arm. As far as surgical outcomes, lobectomy was the most common type of surgery, was performed in 80% of patients in the nivo arm and 72% of patients in the chemo arm, while 9% and 14% of patients in the respective arms underwent pneumonectomy. And about 90% of patients in both arms had an R0 resection. CheckMate-77T met its primary endpoint. At a median follow-up of 25.4 months, perioperative nivo demonstrated a statistically significant and a clinically meaningful improvement in EFS as compared to chemo placebo. Median EFS was not reached in the nivo arm and was 18.4 months in the chemo arm, resulting in an hazard ratio of 0.58 with a significant p-value of 0.00025. The 12-month EFS rates were 73% with perioperative nivo versus 59% with chemo placebo, and the 18-month EFS rates were 70% versus 50%, suggesting greater benefit for patients over time. The EFS per investigator assessment also favored nivo versus chemo based on an hazard ratio of 0.56. And the EFS benefit with nivo versus chemo was observed across most subgroups. Nivo appeared to improve EFS versus chemo regardless of disease stage, and in particular in patients with stage 3 disease. Patients with nodal disease, including those with both single and multi-stage N2 status, had improved EFS with nivo compared with chemo. EFS favored nivo versus chemo regardless of tumor histology, with a particular clear benefit in patients with squamous disease. And in patients who currently or previously smoked, nivo appeared to improve EFS versus chemo, while the opposite was observed in patients who never smoked. But given the limited sample size in this patient subgroup, results should be taken with caution. Nivo also appeared to improve the EFS as compared to chemo in patients with tumor PD-L1 expression less than 1%, and even more profoundly in those with tumor PD-L1 expression of 1% or more. In patients with stage 2 disease, at baseline, median EFS was not reached with either nivo or chemo with an hazard ratio of 0.81. And in patients with stage 3 disease at baseline, a clear EFS benefit with nivo versus chemo was seen, with a median EFS of 30.2 months in the nivo arm versus 13.4 months in the chemo placebo arm, with an hazard ratio of 0.51. In patients with tumor PD-L1 expression less than 1%, the median EFS in the nivo arm was 29 months compared to 19.8 months in the chemo arm, with an hazard ratio of 0.73 in favor of perioperative nivo. The magnitude of EFS benefit with nivo versus chemo was numerically greater in patients with tumor PD-L1 expression of 1% or more, with a median EFS not reached with nivo versus 15.8 months with chemo with an hazard ratio of 0.52. Very importantly, a PCR was observed in 25.3% of patients in the nivo arm, as compared to 4.7% of patients in the chemo arm in the intention to treat population, and an NPR was observed in 35.4% of patients in the nivo arm versus 12.1% of patients in the chemo arm in the intention to treat population. Improvements in PCR with nivo were observed across most subgroups, as defined by stage, tumor histology, current or former smoking status, and PD-L1 expression. We also performed an exploratory analysis of EFS by PCR and NPR status. And EFS clearly favored nivo versus chemo in patients with PCR based on an hazard ratio of 0.33, with a trend toward improved EFS with nivo as compared to chemo in patients without a PCR with an hazard ratio of 0.79. And similar results were seen also in patients with an NPR. And to better evaluate the clinical benefit of perioperative nivo, we also performed an exploratory analysis of EFS by adjuvant treatment status. In patients who received adjuvant therapy, those in the perioperative nivo arm had an improved EFS compared to patients in the chemo placebo arm with an hazard ratio of 0.45. And among patients who could not receive adjuvant therapy after neoadjuvant treatment, EFS still favored nivo as compared to chemo based on an hazard ratio of 0.55. And in patients who received adjuvant treatment, EFS was improved with perioperative nivo versus chemo in both patients who had a PCR and who did not have a PCR. Populations of patients in these subgroups are heterogeneous, so results of this analysis have to be taken with some caution. As far as the safety outcomes, the incidence of all-cause adverse events and treatment-related adverse events was overall similar between patients treated with nivo or chemo. Similar safety outcomes were seen with neoadjuvant treatment, while any grade treatment-related adverse events were reported in 50% of patients treated with adjuvant nivo and in 30% of patients treated with adjuvant placebo. Any grade surgery-related adverse events occurred in 41% and 39% of patients in the nivo and chemo arms, respectively, and treatment-related deaths occurred in 2 patients in the nivo arm, both due to pneumonitis occurring during the neoadjuvant period. The immune-mediated adverse events were generally infrequent, and mild hypothyroidism and thyroiditis were reported in 11% and 2% of patients in the nivo and chemo arms, respectively. So in summary, CheckMate-77T met its primary endpoint, neoadjuvant nivo plus chemo, followed by a surgery, and adjuvant nivo demonstrated a statistically significant and clinically meaningful EFS improvement as compared to neoadjuvant chemo placebo, followed by surgery, and adjuvant placebo in patients with resectable non-small cell lung cancer. And the EFS benefit was seen across most key subgroups, and PCR and MPR rates were also improved. In exploratory analysis, perioperative nivo favored EFS in patients with a PCR, with a trend toward improved EFS also in patients without a PCR. And among patients who were eligible for adjuvant therapy, perioperative nivo improved EFS versus chemo placebo, regardless of PCR status. And neoadjuvant nivo plus chemo continued to provide benefit over chemo in patients who were not able to receive adjuvant treatment. Perioperative nivo-based regimens showed no new safety signals. Surgical feasibility was similar between treatment arms. And so the CheckMate-77T is the first phase 3 perioperative study to build on the standard of care neoadjuvant nivo plus chemo and supports perioperative nivo as a potential new treatment option for patients with resectable non-small cell lung cancer. I'm very enthusiastic about these results because the CheckMate-77T builds on the current standard of care of neoadjuvant nivo plus chemotherapy and supports perioperative nivo as a potential new treatment option for our patients with resectable non-small cell lung cancer. I am excited to see how the data matures. Our next steps will focus on identifying those patients as well as disease characteristics that will tell us who are the individuals who can benefit most from a neoadjuvant chemoimmunotherapy approach alone, and who are the patients who instead require a more intensified adjuvant treatment approach, including the perioperative strategy that we have in a CheckMate-77T, or a switch agent type of adjuvant regimen. Really, the goal here is to try to cure early stage lung cancer for our patients. And I think going forward, this is going to be our goal with more rational studies.